Hip subluxation in cerebral palsy. Video number 4, hip subluxation. Why so much attention? The truth and the myths. So, as I said, I don't really understand to full capacity why there is so much fuss about the subluxation law. There are so many other things which are truly problematic, which are truly essential, but they get a lot less attention, especially when we talk about the quadriplegic child. If I were the person who defined the discourse, I would have focused on the true essentials: connection of the head, position of the neck, depth of the shoulder girdle, flexibility of the back, and so on. So in essence, development of the core. But the fact is, this is the environment that we have to operate, and this is the pressure that you are being under yourself. Plus, well, there are some components which are legitimate concerns related to subluxation, but again, subluxation interpreted in the extended sense, right? So this is where we're going to talk about this clear defining line. Subluxation, as seen by the medical profession, is purely this local selective thinking, right? So bone under the bone, that's it. Everything else are just the negative factors that kind of influence it. Their activities are driven by one single goal. They want to have it under, as if once it's under, then all the negatives would have disappeared. So, but let's go through the details. I divide these approaches into two directions, two avenues of reasoning and two mindsets. Defensive mindsets, that means that what are the bad things that could happen after the subluxation, meaning that once the extra challenges that take place and they put on accelerated pace once the 33% mark of the leg drift has been achieved. That's one thing. And then we also have the proactive mindset, and with the proactive mindset we're talking about the value of, say, subluxation correction for the improvements of the weight bearing, sitting correctly, scoliosis prevention, and so on. So this is also the arguments that are being used by medical profession. So in that sense, again, I've just collected the pile of things which are being used by medical profession and which sort of resonate with you as well. So the first thing is most important: pains. It is important to understand that the pains come in two packages, in two potential forms: soft tissue pains and dense tissue pains. Let's start with the second one. So dense tissue pains is something that you are being sort of, something that orthopedic profession within itself puts a lot of emphasis into. But the fact is that this really rarely happens. Your kids are well nourished, well taken care of. So you see, this is the example of a child, this is the example of complete neglect, which actually leads to this type of deterioration and femur head necrosis and all this sort of bone on bone pains. So fact is, I don't think that this is something that you really have to be worried about. So respectively, when we talk about pains, in reality the legitimate potential source of pains is within the soft tissues. So this is a very important thing to understand. Soft tissues, not the dense ones. Because once you understand then that this is the soft tissues, then there's the next question. Well, the soft tissues, can we actually see them on the X-ray? Surprisingly, we don't. We can't. They're not being visible there. You can see that, there are 30 over muscles that converge from the pelvis all the way onto the femur, right, onto the thigh bone. They're not on the picture. So it seems odd to me to try to make conclusions and to try to prevent pains in the soft tissues by actually brutally interfering with the dense tissues as such, right? Trying to forcefully reposition it, cutting the soft tissues along the line. So that's my line here, that yes, pains to the soft tissues is a legitimate concern. they are possible, but this is not something that is very well aligned with the reasoning that's behind the measurement of the percentage of deviation of the hip of the leg bone out of the acetabulum. If anything, I want to remind that when brutal orthopedic interventions are done, there's no help in terms of pains. Pains don't disappear because, well, forcing the bone in actually causes extra muscular tension, and with the extra muscular tension being caused, well, quite obviously there will be extra pains. So these are the tense muscles, they could hurt. These are the tense muscles, they could hurt. These are the tense muscles, they could hurt. So orthopedic intervention is not the most efficient way of dealing with it. So that's a very simple message. So that's a mixed message here. Yes, this is not a myth. Soft tissues could hurt, especially if we talk about severe quadriplegic individuals, due to the imbalance between the pulls. But this is not the consequence of hip subluxation. It belongs to larger transanatomical challenges that I've already talked about. Let's just have a quick look. When we look at the movement of the leg, what we would see? We would see, yes, hamstrings, they are tight. Can they hurt? Yes, potentially they are. So far, at this point, right, they're not being engaged too much because there is a depression at the abdomen, but they are short. So they are potential source of discomfort. That's the truth. But does that mean that we have to fiddle with the bone itself by cutting it? Does that mean that we have to reduce this larger notion and reduce this analysis of the entire set of kinematic chains and the interactions within the soft tissues to the simplified notion, to the simplified idea of measuring percentages of the drift on the X-ray without ever looking at the channel? So once again, I remind this, that so many cases, parents tell me, well, the doctor never looked at my channel. And it's understandable because they don't need to, because for them, they are treating the X-ray. So this is my point. When we want to understand something that is happening to the soft tissues, it makes sense to do what? To look at the soft tissues directly. I mean, this is not a rocket science. If I'm looking here, I'm seeing that this adductor is tight. Well, true, if it's exposed to loads, it's going to be uncomfortable. But at the same time, if I look here and say, oh, geez, but with this collapse of the abdomen, there is naturally no development of the lower, opening of the pelvis. So therefore, the question is, the adductor, where is it going to be attached to? So of course, it's going to perform as a single lump here. If it's a single lump, well, no wonder it's a potential source of discomfort. So yes, in the long run, we have to bring the full extensibility and full room for movement and full, flow, blood circulation and so on within the potentially uncomfortable muscles. But that's a much larger issue. That's part of the larger transanatomical challenges. It's not the matter of orthopedic intervention. And on the other hand, getting poison into these muscles, right? So if you, for instance, talk about Botox, injecting the poison in it, is it going to change anything about the attachments? No. It's not going to change the situation. It's just going to paralyze it temporarily and deteriorate already poor muscle even further. So weaken it from within. So next concern that I heard about, permanent leg shortness. The idea here is simple, that once the leg kind of pops out, then that's it. There is no way to get it back, and then whatever, it's going to be short until the end of days. Well, frankly, this issue is more difficult to address. But I want you to understand one simple principle, that leg shortness can be evaluated only within the context of the overall position of the pelvis. I want to send this simple message that I want you to understand. It's the twist of the pelvis, the direction of the twist of the pelvis, that defines which leg is short and which leg is long. You see this? What we are seeing here, if we look from the eye, so basically this is the pelvis which is rotated clockwise. If it's rotated clockwise, that means that this leg, the left is in, the right is out. What's the outcome? It's the left leg that's always going to be short, and the right one will appear long. Now we're looking at our model in this video. What do we see? In her case, it's a different rotation, counterclockwise. So what's the result? The right leg is rotated in, the left leg is rotated out. The pelvis is a common stem, and these are the two branches. So now, what are the questions that are coming from the mother? Well, she is concerned about the leg's discrepancy. And which leg is shorter? The right one. So this is my message. You cannot deal with the leg until you've got the stable and steady positioning of the pelvis. So let's have a look at this picture. You see the movement to the right? Watch this, how deep the pelvis sinks here. And now the movement to the left. So what is the point? It sinks less. So both sink, but the right one sink more. I want you to get this image. I'm going to turn it around, and I want you to understand that way. Imagine that was the base. That was the base, and now this is the pelvis that sinks into it. The pelvis that goes in it, tilted at an angle. What's going to happen? This side is going to be short. Anything that grows out of the pelvis will be short. So it's not the subluxation as such. It's not this local X-ray that defines the problem. It's the total twist. And again, the distribution between the long and short leg depends on what rotation of the pelvis is there. So once again, what is the answer? Don't think locally. Don't think subluxation. Think larger transanatomical challenge between the rib cage, abdominal space, lumbar area, pelvis, and only then the legs. Next thing, leg crossing or legs crossing. So this is a point which is kind of mixed. And again, I believe that particular attention to crossing comes from the fact that, especially in the Western world, you tend to associate the profoundly affected child with the child who crosses the leg. This is our kind of typical picture. The person who has the legs crossed, unable to move, so that's profound challenge. So that's what makes it emotionally charged. But we have to put the emotional charge aside and have a look at the sort of true reality there. And again, let's look at the pictures. One more time I'm going to bring you this picture. It's so important because it actually shows us two things at once. You see, on the one hand, to avoid crossing, what do you want? You want strong pelvis that is going to separate the legs, right? So that each of the legs moves in its own hip joint. But does this pelvis, does this abdomen give you the impression of sufficient strength? No, obviously, right? So therefore, what happens? Instead of this division, we hardly have this tiny triangle. So as we have this tiny triangle, both of the legs would have the tendency to fill in this space. So that absence of the abdominal space creates the tendency for the legs to fold and cross. That's the true source. And that crossing comes all the way from here. But at the same time, that same super weak abdomen creates the flatness of the pelvis. So with the flatness of the pelvis, the legs simply do not have any room to move. So basically, with the flatness of the pelvis, there is no movement within, but then there is this line of division. So therefore, effectively, the leg just drops out all the way from here. So if you look from the top, both legs have a tendency to drop out. If you look from the bottom, because of the same deficiency, both legs would have the tendency for profound crossing. So once we fill in this part, what's going to happen? The abdomen will start holding, so the crossing tendency would accentuate. But have we added anything new? Have we created anything negative? Not at all. Because all the wrong things, they're already here. All the tension of the adductors, which don't have any chance to develop because there is no depth of the pelvis underneath for them to get attached to, well, that's the situation. So I want you to look at those things like this. I want you to see the rainbow principle. I want you to understand things are more complex than this. Things are, this primitive interpretation in terms of the x-rays and kind of trying to bring it down to subluxation, it's so primitive. It doesn't give any justice to the reality, and therefore the results are, not surprisingly, very poor. I'm not promising you anything in terms of the easy recipes, but I'm just trying to send this message. Well, first, there is no reason to panic. Second, you have the power to change the situation. Third, in order to change the situation, you have to embrace complexity. You can't just pretend, to stay primitive, simple, and try to reduce the complexity, dumb it down to the, numeric measures of percentages of deviation. This is just absurd. So, and that's what you see. Exactly the point. You heard Emma's mom saying that abdomen is stronger, so therefore that drop outwards that came from the upper abdomen is no longer present. But the lower abdomen is still very deficient. There is still not, this triangle that supposed to separate the legs is still very much a V shape, right? What you want to create, this proper separation that is going to allow each of the leg moving the movement under the pelvis as it is described in the textbooks. So this is the simple message here. No point fighting with the muscles, no point trying to bring the legs sort of forcefully out until we've got the pelvis in between. Simple, straightforward message. It shouldn't be a triangle, it has to be, this inverted trapezium with the legs moving right here. So that's just a brief message. And just to cover it, I want to say, in ABR we have tons of tools to deal with the muscular tension, from direct applications to the linked and so on. So we can deal with pain. We can. Don't worry about this. Just don't get yourself overly bugged by the entire issue of subluxation and the measurement, exact measurement of hip movement. Because you see, this picture here shows you how flawed is this entire reasoning. You see, this, in reality, what happens, as I said, it's the upper triangle here which makes the legs fold out. They just drop out because of the weakness, extreme weakness at the upper abdomen. And then the lower abdomen, the lack of the division, lack of the separation, makes both legs fold in. Now, what do we do about it? So the true development that we actually want, right? So we are building this. We're saying, well, let's add this, and then this, and then this, and then this. So that's how it works. It works from the top. So, but we obviously can't build all at once. So we build this first, right? But as we build this, and then this, the red triangle disappears. So there is no longer a drop out. Now we see this. We see the turn, the city turn in. And what happens? The paradox is that in this case, the hip wasn't moving at all. It was all just the fold above, the fold in the abdominal region. But the abdominal region is soft tissue, right? So it's not in the picture. It's not on the X-ray. So what happens here? Well, they look at it and they say, oh, it wasn't too bad. And now they might say, oh, wow. In this case, maybe it's extra 10 degrees. And that's exactly where the whole thing starts, right? They are numerically oriented. They say, oh, if it was 20 or 25 and now it's 35, bam, the whole industry starts rolling, right? For them, more than 33%, that's the indication of action. Important to understand this. So, and I want you to really sort of repeat this for yourself, maybe even after me. So when we are doing the ABR, we are working on the improvement of the entire set of the trans-anatomical challenges all the way from top to bottom. In that sense, we are not working directly to please the orthopedic surgeon who wants a numerical change, right? Because for them, the ultimate way of pleasing themselves is to fuse the leg and put it in permanently so it wouldn't move. That's their narrow definition. But once they follow their narrow definition, they ruin everything around. Like lumberjacks. The lumberjacks ruining the environment. So you are not a lumberjack, right? So if you want to become the environmentalist, if you want to change the environment, if you want to improve the ecosystem all the way below, all the way to the legs, you have to embrace complexity. And you shouldn't bug yourself with the term of the subluxation per se, or with the sort of plus or minus 10% going here or there. We'll talk about what are the real things that you have to be looking for, but this is the central message here for now. Now, this point sometimes is being used to scare people as well, so that if subluxation is untreated, it is going to translate into dislocation or get into this femur head necrosis. So let's take the second point first. So you see, if you have neglected your child, right, just whatever, malnourished, everything, well, then maybe yes, the subluxation would set the further, after the reach of this 1/3 off mark, then things just escalate and get worse and worse and worse. Well, neglected child. Your child is not neglected. So, next thing, dislocation. Now it becomes interesting, right? So, because that comes following this stupid advice of weight-bearing myth. Because this is the irony, right? Putting this child in any sort of weight-bearing, and obviously I'm talking about any sort of weight-bearing, right? Locking the foot, locking the knee, putting her in the standing frame and so on. I already talked about this in the previous videos on standing frame and so on. That doesn't change the axial distribution. So that's not going to give her anything positive in terms of the mechanical stimulation of the bone. It's only going to stimulate the muscles which are already way too tight, like a hamstring or the hip flexor. So, and then it becomes this irony, kind of self-fulfilling prophecy. These people, they tell you, put her into the weight bearing to improve the legs, to improve the development of the bone. But by doing so without understanding what's happening, because her main movement is here, right, way out of the legs, in a longer kinematic chain, they actually promote this. So, and then by saying do this, do the weight bearing, it's going to help you, they actually cause the tendency towards further deterioration and more in the dislocation, because, well, what happens? The muscular imbalance increases, the pivotal imbalance increases, so the pulls get stronger indeed. So what do they say? Oh, you haven't been, you see, we've done everything right, we have done the weight bearing, but the problem is too great, so we need to cut. So this is my line. If you want to do any weight bearing, if that's really close to your heart, watch my video on the standing frame. That's the principle there. But other than that, don't for the child who doesn't have sitting, don't bug too much with yourself with this point. So inabilities to stand being associated with the subluxation, right? What's the logic here? Very straightforward. You see, this is the way that it's supposed to work, supposed to sit the hip in the pelvis in the healthy grown-up. Well, that's really everything enclosed, encapsulated, and so on. So it's easy to say, oh, look, that's what you want. You want to kind of fit in, and that's the necessary condition of weight transfer, because the bone sort of holds. I'm not going to go into this too much now, because that's a completely separate, big subject. I'll cover it separately, but just want to understand that the most important thing, what is it? Again, the local perception. And we have understood things are trans-anatomical. These are wonderful, complex drawings, right? And that shows you here normal and abnormal here, right? But it has nothing to do with real life, because in real life the pelvis belongs to the upper body, and there are plenty of other sources of movements. So that's the key limitation of this, range of motion thing. They think even the best, and this guy Kapanji, right? So you see the author of this textbook, he is the smartest orthopedic surgeon who ever lived. That's beyond the question. He has the best understanding of whatever. His textbook is remarkable. He's capable to embrace complexity and so on, which the practical surgeons can't. But again, the same flaw. They don't understand this, that the reality is the long kinematic chain. Where does it come from? It comes from the fact that it's only with the fascial understanding, right? Fascial understanding that tells you connective tissue connects, not only connects, it also disconnects, right? So the moment we want, so we have to get back to this connective tissue disconnects as well. Fulcrum and leverage model. Fulcrum and leverage description fails, unable to explain things. And that's what I talked about in the bite integrity thing. Movable disconnections, non-pivotal manifestations of weakness. And you see, that's exactly the same story. That's the fold, right? That's the fold, this is the challenge. This is the fold, this is the challenge. That's the primary source of movement in EMMA. Not the hip. It doesn't fit the textbook. That's what you have to understand. This textbook has nothing to do with the reality, no matter how elegant the descriptions are. Reality is more complex. Reality is trans-anatomical. You have to, if you want new outcomes, you need post-conventional thinking. You need to get out and actually step above. Well, I understand it's not easy because you are being under the orthopedic pressure, under the pressure of that comes from the authority, but that's the reality. And there, because of this, because of failure to understand the transanatomical nature of all the dynamics in the function of the CP chain, once these people move to the advice on how to improve things, go beyond their surgical competence, that's laughable. Because typically they talk about three things: that correcting subluxation is going to help with weight bearing. Well, if that's the case, tell this to these particular people, right? Well, subluxations are, formally speaking, they're corrected, but their weight bearing is really poor. Well, it will improve the sitting. That's obvious nonsense, because this could only be said by the person who studied the textbooks or who tried to actually transfer the X-ray into the reality. That's their main problem. See, that's their perception of the reality. They see the textbook, they see the X-ray, and then they just transfer it into the reality, making the selective perception. So you see, it's really mind-boggling in the sense that, let's forget about the textbook for a second, right? See, look at this. What is the key challenge for her sitting? Is it at the bottom or is it at the top? See, below or above. That's one thing. And the second thing, where does it come from? From here or from there? From the top or from the bottom? Is it descending or is it ascending? And that's what we can see here, right? Unless we start asking this, we'll never be able to answer things, right? If we just think that everything that happens above is defined by this, by the shape of the platform that she sits on, well, it's just so pitiful, you know, thinking like this. It's amazing. It's so primitive. So for her, you can see that it's the pelvis that sinks, and that comes from the abdominal weakness. It comes from the transanatomical challenges. So no matter how you fiddle with the legs, chopping them, it's not going to help a single bit in terms of sitting. A person who says that correcting subluxation is going to help surgically, right, is going to help with sitting, has no clue about sitting. That's a very simple conclusion. So what I want you to understand, right, I try to make this in a more compact version. It's still 33 minutes long. So I hope that by listening to the previous one or to this one alone, you know, two versions of the same thing, you would be able to get a better idea of the distinction between the truth and the myth. Yes, subluxation in the extended sense indeed is associated with these potential challenges, pains and within the soft tissues. But to work with this, to understand and to be able to manage it, we don't need X-rays. We don't need looking at the X-rays and try to figure out the soft tissues from the picture where we don't even see them. That's a mind-boggling paradox. Trying to solve the riddle without actually seeing what we're doing. Why do we have this long road? You know, taking this paradox, this is, you know, strange. It's like walking one way, walking away from the soft tissues when we actually want to help the soft tissues. So, now, when it comes to the leg shortness, no point talking about it unless we improved the overall position of the pelvis. And I pointed out to you that depending on the direction of the corkscrew, you have the shortening. If the legs are rotated, if the pelvis is twisted clockwise, it's the left leg which is short, and the right one is long. In that sense, right? Visibly. Because the pelvis sinks unevenly into the abdominal area. And if the whole thing rotated counterclockwise, it's the other way around. It's the right leg which is short. I've given you the examples. Crossing, I want you to understand that crossing is nothing, it's not a challenge in itself, it's not a problem, it's just a reflection. And again, it has components and tools, we can deal with it. But deal with it within the rainbow principle of transition, with the rainbow reality of transition, and within the larger transanatomical context. Dislocation femur, if you don't put the child into this silly weight bearing, that's not going to happen. And femur head necrosis, well, you have to really neglect your child. So, and again, all these things, they only happen if you do things in a mindless way, trying to fit your child into the textbook. So, I hope that between these two versions of the same sort of subject, you get a better understanding of the idea. In the next video, I'm going to talk about, try to get this next angle and say, well, subluxation, what is it? Is it a problem or is it the manifestation? So, kind of reflection of a larger thing. So, I'm trying different angles, I'm trying hard. I hope that it's helpful and that by looking at these different facets, eventually you'll be able to construct a larger picture. And my only message to you is that, first of all, don't fall under, prey to the pressure. There are lots of people who want to scare you. There are lots of people who want to do some, lumberjacking in the forest, and you need to be really. You have to take matters in your own hand. You have to understand things, right? You have to take a larger picture. You have to get the understanding of the larger picture. You have to understand what is the cause and what is the effect, and you have to understand what are the tricks which are being used, and you have to understand the difference in the mindsets and the perspectives between you and the people, so-called professionals, who put pressure on you. But on the other hand, I want to sort of ease your mind and say, well, in terms of the soft tissues, in terms of pains, we deal with it. In terms of the wrong alignments, we're able to deal with it. Just have to, but that is within the larger context, within the larger framework of transanatomical challenges. So if you expect that with ABR we're going to keep the orthopedic surgeon consistently pleased, again, it's unrealistic. They have different mindset, they have different criteria, they have different wants and desires. They want to cut, so they're going to use any opportunity to do this. So that's the reality, that's the situation. I hope that your knowledge base is increasing, but any questions, any comments, anything that could help me to serve you better, to kind of add facets of understanding, is most welcome. Thank you.